Good afternoon, everybody, or good morning, depending on where you are in the country. We're just going to wait one more minute. We can see that people are signing in right now, and we know that it's been a little difficult for some people to sign in, so we might give them just one more minute, and then we'll get started on today's webinar. Okay, so once again, I want to welcome everybody to today's webinar. This webinar is being hosted by SAMHSA's GAIN Center, and today a panel of experts are going to be sharing information on getting started, essential measures for data and information sharing across the Sequential Intercept Model. I'm Maureen McLeod, and I'm a Senior Research Associate with the SAMHSA GAIN Center at Policy Research Associates, and I will be serving as the moderator for this event today. Before we get started, I want to share the following disclaimer with you. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. The virtual learning community on data and information sharing has been structured to really partner a 1-hour presentational webinar with a 1-hour open discussion group, which follows immediately. A number of you submitted some questions ahead of time when you registered for the webinar, and we will address as many of those as we can, either at the end of the webinar if there's time, or certainly during the discussion group portion of this event. You can always type in additional questions in the Q&A pod. You'll see it on the right-hand side of your screen. So if you have any questions, just type them in there. All of you will be muted during the webinar portion, but we'll be able to see the questions that you type in. The webinar is being recorded, and the slides will be ready for dissemination in a few days. At the end of the webinar portion of today's event, a certificate of attendance will be available for you to download. Okay, so on this slide, you can see the agenda for today. Dr. Victoria Chow from SAMHSA's Office of Behavioral Health Equity and Justice Involved is with us today to welcome the registrants and to provide some additional information about the Data and Information Sharing Virtual Learning Community Series. After her welcome, I'm going to introduce our webinar presenters and our discussion group expert participants, and I will provide a brief overview of the webinar supporting document, which Dr. Chow will be introducing to you. So Dr. Chow, if you're ready, I would love to hand the microphone over to you. Actually, we seem to be having some difficulty getting Dr. Chow online. So what I might do is to, when Dr. Chow gets back online, we will bring her in to provide her introduction. But the virtual learning community series.
Is this working now?
Yes, Dr. Chow?
Okay. Okay, let's try it again. Thank you, Maureen.
Right, here we are.
On behalf of the Substance Abuse and Mental Health Services Administration, also known as SAMHSA, welcome to the Data and Information Sharing Virtual Learning Community. This is hosted by SAMHSA's GAIN Center. The GAIN Center is SAMHSA's National Technical Assistance Center focused on expanding access to services for people with mental and/or substance use disorders who come into contact with the justice system. Today's current circumstances with the COVID-19 pandemic are at the forefront of everyone's minds. We at SAMHSA would like to acknowledge that we understand that the pandemic has further complicated the work and lives of everyone and is especially impacting those who are most vulnerable, including the incarcerated population and their behavioral health. In the U.S., prisons and jails are overrepresented with individuals who have mental and substance use disorders. In alignment with SAMHSA's mission to reduce the impact of substance abuse and mental illness on America's communities, SAMHSA recognizes the need for mental and substance use disorder treatment for individuals in contact with the justice system. SAMHSA continues to promote collaboration and partnerships across disciplines and sectors to better serve individuals with mental and/or substance use disorders and who are at risk for or who are already incarcerated. In this intersection of criminal justice and behavioral health, SAMHSA continues to promote the identification of individuals with mental and/or substance use disorders, use of evidence-based screening and assessment during pre- and post-adjudication, diversion of individuals from the justice system into home and community-based treatment, provision of training and technical assistance for law enforcement officers, juvenile and family court judges, probation officers, and other judicial decision makers, and the assurance of equitable opportunities for diversion and linkage to community services and supports for all populations in order to decrease disproportionate minority contact with the justice system. Today's webinar, titled Getting Started, Essential Measures for Data and Information Sharing Across the SIM, is the first of 3 webinars for this virtual learning community. Last year, SAMHSA released the publication Data Across the Sequential Intercept Model, Essential Measures, to help support jurisdictions interested in using data to better understand and improve the outcomes of people with mental and/or substance use disorders who come into contact with the criminal justice system. This webinar will provide an overview of this publication and will include examples from 2 counties describing how to practically apply the information locally. Invited speakers will share about their work to facilitate effective data and information sharing. Today's webinar will be followed by a second webinar on June 24th, focused on addressing data sharing agreements and confidentiality concerns. The third webinar will be in July, focused on mechanisms and platforms for efficient data and information sharing. During these challenging times in this current environment, SAMHSA would like to thank the GAIN Center, the speakers, and the participants on this webinar for your participation in this virtual learning community and your continued dedication to improving the behavioral health of individuals incarcerated in the criminal justice system. Maureen, back to you.
Thank you so much, Victoria. This is such a wonderful welcome. Today, as Dr. Chow mentioned, we have 2 presenters who will be sharing information about programs and lessons learned as they've implemented data and information sharing initiatives in their local jurisdictions. Jesse Benet is the Deputy Director for the Public Defenders Association in Seattle, Washington. Previously, he led the King County Familiar Faces Systems Transformation Initiative, a cross-sector, data-driven, analytical approach to serving jail high utilizers. Jesse also served as Section Manager for the King County Behavioral Health and Recovery Division's Diversion and Reentry Services. Also with us today is Stephanie Robertson. Stephanie is the Contract Compliance Coordinator in the Division of Community Corrections for the City and County of Denver, Colorado. She's worked with a variety of nonprofit and governmental organizations to support adults and children who identify as female, are in recovery, have experienced trauma, are system impact, and or are formerly incarcerated. After the webinar portion of today's event, Both Jesse and Stephanie are going to remain online as discussants during the discussion group component of the session, but they're going to be joined by two other expert panelists, who I'd like to introduce now. So Tyler Corwin is the Behavioral Health Evaluation Lead in the Performance Measurements and Evaluation Unit of the Department of Community and Human Services in King County, Washington. In this capacity, he supports the Behavioral Health and Recovery Division to divert individuals with behavioral health needs away from the criminal justice system. Tyler coordinates data sharing across a variety of system partners, including courts, public defense, prosecution, law enforcement, jails, and prison, to support program administration, operation, and evaluation. And just from reading his bio, you know that he's going to be an invaluable member of our discussion group today. And Dr. Melissa Stein is a Senior Research Associate with SAMHSA's Gaines Center at Policy Research Associates. She facilitates SIM mapping workshops and is a trainer for the How Being Trauma-Informed Improves Criminal Justice System Responses trauma curriculum. Melissa is a former criminal justice planning manager for Mecklenburg County, North Carolina, and was a Senior Research Associate at Justice Policy Institute in Washington, D.C. As Dr. Chow noted in her welcoming remarks, today's webinar and discussion group is the first of three of the virtual learning communities focusing on data and information sharing across SIM. Recognizing that many jurisdictions are seeking assistance in their efforts to use data to better serve justice-involved persons with mental or substance use disorders, today's event examines those essential measures for getting started with the data and information sharing process. As Dr. Chow pointed out, SAMHSA's Gaines Center produced an action brief entitled Data Collection Across the Sequential Intercept Model, Essential Measures, just last year. This document will be available for download at the conclusion of the webinar. After an overview of the history, structure, and application of the SIM, the guide provides a compilation of data elements focusing on data elements to be collected in response to questions that local jurisdictions oftentimes strive to answer in their efforts to better serve clients. The document also describes two data collection approaches and discusses when each approach might be more appropriately employed. The gathering of aggregate data, for example, can be used effectively to describe volumes of persons with mental and substance use disorders moving through the justice system. A second approach entails the collection of data with personal identifiers that can be used to track specific individuals as they make contact within and across the criminal justice and behavioral health systems. At each of the SIM intercepts, challenges to obtaining data are identified and addressed in the supporting document. These challenges are fairly diverse and include concerns related to funding, cross-system collaboration, privacy and confidentiality, research methodology, and mechanisms for data storage, access, and analysis. And while several of these concerns are going to be addressed in this first webinar, the others are going to be addressed in subsequent webinars in this series. Although I think many of you are familiar with the Sequential Intercept Model, there we go, just providing an illustration of the SIM. A SIM was introduced, it's hard to believe this, but almost 2 decades ago. It provides a graphic representation of the fairly predictable ways by which a person with mental or substance use disorder enters, proceeds through, or is diverted away from the traditional criminal justice system. The SIM is used to identify community gaps in resources at each phase of interaction with the justice system, beginning at Intercept 0 all the way to the left, which is the crisis response, and ending with Intercept 5 all the way to the right, which is community corrections. In the resource document, the local applications at each intercept are showcased, and during the individual showcased applications, there's discussions about possible community issues, data-related questions to be asked to address the issues, and potential challenges to successful data and information sharing. And I just want to share a few examples with you to give you a flavor of the content of this action brief. For example, at Intercept 1, which is the intercept that looks at first contact with law enforcement, imagine a local jurisdiction that strives to improve the efficiency of law enforcement response to behavioral health calls based on what comes into dispatch. Well, an important data-driven question focuses on the magnitude of the issue. What proportion of the 911 calls might require a behavioral health response? Well, one of the challenges for using data to answer this question may be logistical. I mean, how do you share data that's collected by a dispatch with an existing law enforcement data system? Sometimes the data are collected on very different platforms, and it's difficult to simply share data on systems that don't easily talk to each other. At Intercept 2, the intercept that takes a look at intake, arraignment, pretrial services, a community that acknowledges that screening for mental and substance use disorders can promote early diversion may want to know how many persons are so identified so that the jurisdiction can more effectively plan for and fund diversion services. To do so, they may want to employ one of those aggregate data collection approaches. A challenge, an operational challenge, is that screening requires additional staff time. And how does one pay for, as much as you might want to do or engage in a certain strategy, how do you fund the additional staff time that would be necessary for universal screening? There. Intercept 4 looks at reentry planning. Now, evidence-based practice informs us that persons with behavioral health needs who are released from jail or prison are most successful if the continuum of care is maintained. A frequently encountered obstacle is the adequacy or inadequacy, I suppose you could say, of medications that are provided to releasees to bridge the gap between release and that first behavioral health appointment. A jurisdiction that wants to assess the adequacy of their own current protocols may run into difficulty to do so if they discover that the data elements they need to engage in that assessment aren't even being collected currently by the jail. So that's another challenge that may be encountered in some jurisdictions. And Intercept 5, which focuses on community corrections, evidence-based practice informs us that data sharing across systems promotes personal recovery and reduces recidivism. When clients with behavioral health needs on probation are unsuccessful, that is, their community supervision is revoked, it's beneficial to have some understanding of the reasons for the revocation decisions. The data need to address that question might be data that requires some type of tracking and sharing of medical records of specific individuals. We, I think, immediately can see what some of the challenge is there. The privacy concerns related to the disclosure of healthcare information with non-healthcare personnel. Okay, now I'd like to turn the presentation over to our local experts for a description of data and information sharing efforts in their communities. Again, I want to remind you, if you have some questions, please type them into the question and answer pod on the right-hand side. And I see we already have a question. Somebody was just saying, hope we could quickly take a look at Intercept 3 slide again. There actually wasn't an Intercept 3 slide because I was just giving you a kind of a taste. So I did, I think, 1, 2, 4, 5. But certainly we can talk about that later during the discussion section. So Jesse Benet from King County, Washington is going to be our first presenter, and Jesse's going to be focusing in on initiatives at Intercepts 1 and 2. So Jesse, I'm going to turn it over to you.
Thanks, Maureen. Good morning, West Coast, and good afternoon, East Coast. Thanks for joining. Again, Jesse Benet, the Deputy Director of the Public Defender Association, but I did spend about 12 and a half years working for the King County Behavioral Health and Recovery Division. I'm going to talk to you about 2 different sort of efforts around data, what I consider data-driven justice. The first one I'm going to talk to you about is the King County Familiar Faces Initiative, which was a systems mapping and continuous improvement initiative that we did looking at jail high utilizers, folks that were cycling through our jails 4 or more times in a given 12-month period. I'm going to talk a little bit about the data matching that we did. It was a pretty large body of work, and so we'll have time in the breakout group later to unpack it a little bit more. And there's a very good website on the King County, Washington main page, our executives page, that has tons of information about our Familiar Faces initiative. And then the next effort I'm going to talk to you about is the expansion of the law enforcement assisted diversion program to what we call in Washington State our Trueblood population. And so for those of you that have cases in your states around the legal competency population, folks that can't assist in their own defense or don't understand the nature of the charges against them, that have been languishing in our jails nationally. In Washington State, our lawsuit was called Trueblood. And so I'll talk a little bit about lead expansion to that population and how that was sort of informed and driven by our Familiar Faces initiative. And so just going back to 2012, 2013, when our Familiar Faces initiative came to be, the county was really thinking about healthcare transformation and healthcare integration, and also wanting to look at a population of folks cycling through our jails and understand that population better. There was a lot of work being done around the country. People were talking about high utilizers and super utilizers, and in King County, because healthcare integration, behavioral health with primary care integration was on the horizon, we really wanted to look at a complex healthcare population, but also look at, the number of folks cycling through our jails. And so we also were having a lot of introspection and thinking about the criminalization of substance use and mental health disorders and poverty and homelessness. Our law enforcement assisted diversion program was born here in 2011, and that was born under a racial disparity project. King County also had launched our King County Equity and Social Justice Initiative and really wanted to look holistically at folks that were cycling through our system, which, as I talk a little bit more about the Familiar Faces data, you'll hear. And then also just the cost. We know it costs a lot to hold folks in jail that have psychiatric conditions, and people with high mental health issues are often in jail much longer. Just a little contextualizing, and this is important because the effort around data matching and data-driven approaches in King County was really born back in 2001, 2002, when my former department that I worked in, the Behavioral Health and Recovery Division, entered into a memorandum of agreement, our initial data sharing agreement with the King County Jail. And so in Seattle and King County, the jail is a 2-site effort. The downtown jail in Seattle, the King County Correctional Facility, which is also known as being the second largest psychiatric facility in Washington State, the 7th floor of that jail. And then another site down in Kent, which is South King County, a little bit smaller of a jail. So those 2 jails together book about 38,000 people a year and have about 37,000 releases. The overall census of King County is about 2.2, 2.3 million. And the average daily population in the jail in 2018, that takes the day a little bit while to get refreshed, is about 2,000. And it's obviously a little bit lower now under COVID conditions. So the jail booking data was matched with all of the publicly funded behavioral health system data. And so the Behavioral Health and Recovery Division, where Tyler works, gets every single Medicaid-funded, publicly funded mental health and substance use agencies data nightly. And then that data is then matched nightly with a data file from the jail. And so we are able to see in real time every day who's been booked in and out of our county jail system. And that was really the effort that sort of set the groundwork and led the way for Familiar Faces efforts and other data-driven efforts that we've undertaken. Just making sure I'm looking at my timer and not going too far over. Okay. The Familiar Faces initiative, I'll come back to this in the discussion, but the initiative was very cross-sector, very multi-sector, a huge cross-section of behavioral health, housing, mental health courts, drug courts, probation, law enforcement, all 5 managed care organizations that work in Washington State coming together to look at how people were cycling through the jail and then create a vision for the future. And this was over a long year effort. So probably the largest table we ever set for people looking at the intersection of behavioral health conditions and criminal legal system involvement. This map is the vision for the future. I like to say this is my life's work. Even though I've left the county, I still very much believe and am driven by this future state vision. And I won't go too far into this. We may have time in the discussion. I'll just call out a couple things. On the left-hand side, you see the Familiar Face in the middle of the map. They have a portfolio of health and human services around them that are accessible. They are able to access brick and mortar sites and mobile response in a preventative and pre-crisis mode. If folks do come into contact with law enforcement and first responders, they're diverted back either to diversion sites or Health and Human Services response, and then hospitals, jails, and courts become institutions of last resort. There's many core concepts at the bottom that were also guiding principles of the Familiar Faces initiative, that things were done in a person-centered way. We were doing things from a motivational interviewing, trauma-informed, and harm reduction approach. Law enforcement-assisted diversion was very much sort of informing that approach. And as I talk a little bit about the data and what we learned from the data, there's really good reason for that. We learned that our Familiar Faces were not responsive often to clinic-based or compliance-based services. There's some very interesting data in the data packet about the number of Familiar Faces that actually came into our local therapeutic courts. The sort of claim to fame and the biggest item that we found out about the Familiar Faces is that 94% of them, so these are people 4 more bookings in a given 12-month period in our King County Jail, 94% of them had some sort of behavioral health condition. That data was based on the Behavioral Health and Recovery Division's data system, the correctional healthcare provider in our county jails, Jail Health Services, that's part of our public health, matching of those with many other data sets. This was a huge endeavor, and it's kind of funny that different county departments actually had to enter into memorandum of agreements with ourselves. So our public health department and our Department of Community and Human Services actually had to have a data sharing agreement with the jail so we could pull together the initial data packet for Familiar Faces. Like I had just said, we were also finding that only 8% of our Familiar Faces were opting into our local therapeutic courts. So thinking back to drug court movement proliferation in the mid-90s and going into, the Seattle and King County were the 2nd and 4th mental health courts in the nation. That was our best thinking back then for people that were cycling through the jail with behavioral health conditions. But then in 2013, here we see that actually a very small amount of our jail high utilizers were opting into those courts. This is just a visual depiction of the types of behavioral health conditions. We also found that people had a lot of chronic and acute primary care conditions, And then the other thing that was a bit earth-shattering for all of us as we were looking at this data is we found out that about 41% of the charges that people were cycling through the jail were related to compliance or non-compliance. So not showing up to a court appointment, not showing up to a probation appointment, having a failed urinalysis, and many other things that a court might ask somebody to do and they're not able to comply with that. So not necessarily, not new charges, not actually committing new crimes. Okay, I know I'm on a fast trajectory here of trying to get all the information out to you. So the other effort that I am going to talk about is how we expanded our law enforcement assisted diversion program to our competency population. And so the way that LEAD operates is very much in alignment with the Familiar Faces Future State Vision, and the Future State Vision was certainly informed by it. And one of the things that we were learning is a lot of our familiar faces were being sent to local behavioral health clinics for clinic-based services where they'd see a case manager once or twice and maybe wait 6 to 8 weeks to see a psychiatric provider. And, you know, over 600 of them were enrolled at one of our largest behavioral health providers here locally, but still cycling through the jail. And so we were really trying to understand and unpack, okay, business as usual, treatment as usual, wasn't really getting the job done, so what would? And that was right around the time that we were learning from the Reach case management program that was providing the LEAD case management, the outreach-based, really guerrilla outreach, street outreach-based services, and really meeting people really where they're at from a true harm reduction approach was a way to get at a population that was just kind of falling through the cracks, cycling through jail, not making it to community-based behavioral health clinics. This picture on the left is just a visual depiction of the LEAD model. I know that this is a known model nationally, so I'm not going to go into it a lot. Just to summarize, it is a sort of magic formula of prosecutors, law enforcement, and the Reach case managers, and then there's different business associations and other community involvement involved in the LEAD model. And then the Public Defender Association, actually where I work now, actually holds a shared memorandum of agreement with all of those entities, and so the care coordination and the collaborative process can happen. These prosecutors meet twice a month, or sorry, this group all meets twice a month. So pivoting to our Trueblood lawsuit in Seattle, or sorry, in the state of Washington, that was a lawsuit where the State Department of Social and Health Services was sued as a class action suit for people languishing in jail, either waiting for a competency evaluation or post-evaluation, waiting in jail to go down to our state mental hospital for competency restoration. And that's all I'm going to say about that. There's a lot of information about that, and we can unpack it more in the next discussion. This lawsuit, the state started paying fines to a federal court, and we had a federal court monitor, and those fines got up to about $80 million, and the federal court and the federal court monitor, Dr. Donna Mosh, who's actually from back east, were able to put out funds, to RFP out funds to jurisdictions around the state that wanted to do either diversionary or alternative approaches based on the sequential intercept model. And so we decided that we wanted to use the classic LEAD model that I just showed you to expand that model to look at this higher mental health, this competency population. That wasn't historically typically the sort of classic LEAD population. Before we did anything about program design or thinking what that would look like, we really wanted to be data-driven in our approach. And so the top 3 competency driving or producing courts in Washington State are right here in Seattle, King County, our Seattle Municipal Court, our King County District Court, and our King County Superior Court. So we looked at cases from those 3 courts. Because we had relationships with those courts from a long history of work around reentry, and because we had jail data, we were actually able to get quarterly data from each of those courts on all of their competency cases. That came into Tyler. He matched that with behavioral health data and jail data, and we were able to start to look at and unpack, okay, what are the charges that people that are being arrested on these competency-related charges, what do they look like? What would we need? What would be the charges that folks would have to be eligible for in LEAD to be able to access sort of a different approach. And so the graphic on the right, those are the top competency producing charges, if you will. And then Washington State, about half of everybody that has a competency raise and has an evaluation comes back not competent, and that makes the pathway of the case go one way, or they come back competent. Obviously, the pathway of the case may go a different way. So this is that whole group across those three courts, and you can see on the right what some of the top charges were: assault, criminal trespass, harassment, property destruction. We can unpack that a little bit more in the next discussion, but that was like, okay, if we want to expand LEAD to this population, these are the charges we would have to think about being able to divert. So as we were planning for that and having conversations with law enforcement and prosecutors and sort of thinking this through, we also wanted to think about what would this population need. And based on Familiar Faces learnings early on, we came up with a different care management approach. And I know there's not a lot of time to talk about this, but basically it's adding kind of a modular approach to what the classic LEAD program was doing around case management, having intensive behavioral health services, some dedicated housing, and having also the framework of classic LEAD around coordination with prosecutors and law enforcement. I know I'm getting really low on time. So my last slide, these are some of the key data sharing partnerships that we've used both with our Familiar Faces initiative and with other data-driven initiatives as we go into program design. Before the county or sort of any entity locally develops any sort of new program that's targeting the population of folks with behavioral health conditions that come into contact with the criminal legal system, we really try to think about looking at, like, what is our target population? What is the problem that we're trying to solve? And it's through interagency agreements and data sharing agreements with these entities listed here that Tyler can talk a little bit more about in the next section, that we are actually able to pull that data together and, perform that analysis. And the Familiar Faces data packet, I'll make sure that link is available. That is just a really good example of how we did that in the Familiar Faces initiative that then drove the work forward from there. And I believe that is my last slide. That's quick contact information on Tyler and I. And next up is Stephanie Robertson. So over to you, Stephanie.
Thank you. My name is Stephanie Robertson, and I'm the Contract Compliance Coordinator with the Division of Community Corrections for the City and County of Denver. So my team supports collaborative efforts in helping our clients achieve their goal and move on to healthy and productive lives. Community Corrections offers a sentencing or placement alternative that combines residential supervision and treatment for clients that are not eligible for probation supervision. So that's what I call a diversion client, or those folks who are returning from prison to the Denver community. We call those transition or parole clients depending on their status. Denver Community Corrections recognizes the vital role that the Sequential Intercept Model has in improving outcomes for all stakeholders. As a strategic planning tool, Denver is developing a comprehensive picture of how people with mental and substance use disorders flow through the intercept points. We identify gaps in resources within community corrections for adults with mental health and substance use disorders, and we're using data to develop priorities for system and service level improvements. You'll notice on this slide that our community corrections model is situated as a transition point between the carceral institution and the community. When looking at any particular intercept, it's important to remember to adhere to the best practices across all intercepts. So coordinating for cross-systems collaboration, our coordinating bodies serve as an accountability mechanism and improve outcomes by fostering community buy-in, helping develop priorities, and identifying funding streams. There's ongoing reciprocity between the various intercepts as clients flow between intercept points. We believe that it's critical to have both formal measures of system review as well as maintaining constant communication with all providers of services. There's been an intermingling of state and local data systems, which allows review of successful outcomes at each intercept. They assist us in being accountable and also help us bridge the gaps that might otherwise go unnoticed. Transmission and data exchange occurs when a client moves from one intercept to another. Sometimes this occurs through the integration of electronic systems where providers have access to databases and systems of the providers at the other intercept. And sometimes this data transmission is done through faxing or emailing of releases of information. So we routinely identify individuals with mental health and substance use disorders. Individuals with mental and substance use disorders are routinely administered validated assessments, brief screening tools, and follow-up assessment as warranted. All providers of community corrections perform a core level of supervision and treatment practices according to the state standards. In addition to the core standards, some providers have specific programs targeted for clients who have various levels of substance use disorder and mental health disorder. We use assessments and data to determine which levels of services are most appropriate for the client. We use the assessments that are provided by the referring agency. Whenever possible, we use the existing data in the decision-making process in order to provide continuity of care. New assessments are only completed for clients who require them. As a point of emphasis, it's critical that entities trust each other's assessments. So internal fidelity practices are key to enhancing that trust. In Denver, we use tools such as the Colorado Criminal Justice Mental Health Screen Adult for the mental health screening and the Standardized Offender Assessment Revised for assessment of substance misuse patterns. It's critical to cross-train on assessments and tools. When new tools are implemented on one intercept, we try to assure that the folks who are working at other intercepts are trained to interpret those tools. A great example of this is the Women's Risk Need Assessment. When probation in the prisons began using that tool, community corrections staff and community providers were also trained to administer or interpret those tools. It's also imperative that continued access to treatment, support, success include Medicaid and Social Security disability income is provided. In Denver Community Corrections, clients are connected with Medicaid enrollment prior to discharge from prison or jail. Being a Medicaid expansion state helps. Clients are also given access to enrollment at their community correction site to assure that no one has fallen through the cracks. For those clients with disabilities, the Social Security disability income application process can be a super lengthy one. By planning an Intercept 4 for the client's needs in Intercept 5, we can reduce that client's risk of experiencing crisis. In terms of information sharing, those practices can assist communities in identifying frequent utilizers, provide an understanding of the population and its specific needs, and again, help us identify those gaps. Information sharing can be done either through sharing centralized databases or through the use of releases of information at the individual level. Those who are utilizers of services at any one intercept should never have to start at square one when transitioning to a new intercept. We share information at this level to assure continuity of care occurs and that we can leverage the strength of the current intercept to enhance that client care. Just as involved people with mental health and substance use disorders should have access to individualized services, community corrections clients who have mental health or substance misuse treatment needs are assessed as either needing specialized on-site treatment services or off-site treatment services. Comprehensive case planning at the facility includes goals around access to treatment services, both while in the facility and upon discharge. So this is what our system looks like. So transition planning is done by the jail or in-reach providers. Staff from community corrections facilities that provide specialized programs or our female programming regularly have access to our prisons and jails to assure that relationships are developed and adequate transition planning can occur. Medication and prescription access is again coordinated at both levels. So regardless of whether they come from prison or jail, they are all provided with access to critical medications, particularly mental health medications. This includes funding for medications, access to prescriptions, and transmissal of medication lists. That warm handoff piece is really important. So community corrections staff pick up an individual at their carceral institution and transport them directly to the halfway house in order to support those positive outcomes. From the moment of release, there's somebody there to support that transition process. Warm handoffs occur with community agencies who partner with the community corrections facilities as well. They're encouraged to visit the client in the halfway house. This allows the client to establish trust and rapport with the provider and then transition to that community provider's location at a later time. Regular communication is also required with monthly updates going from the community provider to the Community Corrections Agency to make sure that any changes in treatment or care are thoroughly documented verbally when possible, but at minimum in writing. Specialized community supervision caseloads of folks with mental health disorders. So we use specialized residential programs to address those clients with the highest level of mental health needs, substance use disorder, or co-occurring treatment. Within those specialized programs, caseloads are really tailored to help meet those clients' needs. In non-specialized programs, clients are matched with case managers who are trained to meet the more common needs. Treatment data is retained in a statewide database and can be accessed at a micro-individual level or at macro level for population data. All programs develop long-term relationships with community providers. This allows providers to develop trust and rapport that's really essential for that quality communication. Medication-assisted treatment, which I'll refer to as MAT, is a vital component which reduces relapse episodes and overdoses among individuals in community corrections. So our Jail to Community program allows persons who've not been on MAT previously to enroll in MAT programming while they're in the jail. That includes induction and early treatment phases. Access to this care continues when they transition to the halfway house. The clients are given prioritized access to care and continuing services through one of our local hospitals. In most cases, we sign releases of information and notify providers from both the criminal justice side and the treatment side of the names, emails, phone numbers, and other contact information prior to the transition occurring, reducing the barrier for the clients and increasing our ability to collect micro and macro level data. Regular meetings and sharing of research data occurs on an ongoing basis between those stakeholders. Our Department of Corrections has recently implemented some forms of MAT in its institutions. Those clients are continued on those services when they transition into the community. Housing and employment are just as important to justice-involved individuals as access to mental health and substance use treatment services. So we reduce those barriers by partnering with community providers who tailor services to meet the needs of formerly incarcerated persons. That makes sure that the resources are not only appropriate, but they're really welcoming to folks who experience some social stigma. Community corrections case managers also obtain releases of information to coordinate care with community providers. This means that routine communication occurs through monthly updates, crisis communication, and discharge planning. This way, all services can be coordinated effectively and efficiently. We also regularly communicate with referral agencies to help them understand both supervision requirements and any changes in a client's ability to participate in programming. So this has been a process, and it is an ongoing process, and some lessons we've learned. It's really important to identify a champion for the Sequential Intercept model. This person can coordinate efforts and advocates for utilization of the model. They should believe in the importance of the model and agree to be the local champion. They can be tasked with maintaining resource lists, points of contact, understanding how all the stakeholders are connected. In Denver, we have Lynn Unger, who's the program administrator at the Denver County Court. She uses the Sequential Intercept model to evaluate and inform design. She encourages people to talk about it and garners interest really through her own infectious enthusiasm, and we are grateful for her role. It's also important to break down silos, which can occur in several forms. They can exist between intercept points or among stakeholders within an intercept. Communication and collaboration are always the key to breaking those down. It really means developing a shared language, understanding perceived barriers, and treating challenges as an opportunity to develop partnerships instead of inciting some animosity. Stakeholder education is also critical, and it's important not to make assumptions. Sometimes that education is specific about a highly technical point of consideration, and sometimes it's as broad as helping a stakeholder understanding where they fit into the model. The definition of a stakeholder is broad in that sense. It includes people who provide professional services at each intercept, political and governmental figures, the clients, and the community at large. So, identifying your funding streams is really critical. It can be helpful to look at where the money comes first. So the county behavioral health department, it's often easier to figure out who's getting the funding and then leveraging the strengths of the services that already exist. It's not so much about creating brand new services. It's about what using you have in a way that's better. In terms of overcoming barriers, it really is a use it or lose it. There's a lot of great research out there about the model. Educating yourself is an important first step, but it's only a first step. Next, you build the model, and then you need to use it. Talk about the model regularly and frequently in staff meetings and any other place you can talk about it, being sure to update those documents whenever new resources are developed. We know that there's can be some fear and some myths around 42 CFR and HIPAA, and in general, people seem to operate under a policy of when in doubt, don't do anything. There's actually a lot of communication that can occur, and people shouldn't be afraid to share data and talk with one another. The Council of State Governments put together a booklet a couple years ago that I can link to in our next section, really helping to educate partners and the way we can work together. People must perceive the model as valuable. So this means keeping the model up to date. If the information isn't accurate or relevant, people won't use it. Data should drive the dialogue from both a micro and a macro perspective. For an individual, it means exploring how many contacts they had and what those interventions were. Often folks at other intercepts believe there were no resources offered at prior intercepts, so really by looking at the data for that individual, it gives us a more comprehensive picture. Denver's Department of Safety has data on persons who appear to be frequent utilizers of services provided at one intercept, and then we use that information in later intercepts to inform our decision making. We also track individual information in that space between intercepts 4 and 5. Right now, an interesting space to explore would be that cohort level data that would really let us track someone, a group of people, really from the very beginning all the way through the process. I just want to acknowledge that COVID-19 can feel really consuming at times. The truth is, we just keep doing what we do. Since most of our stakeholders are considered essential, and most critically, our clients that we serve are fundamentally at risk and essential human beings, the wheels of justice and service need to just continue to turn. We're making some additional efforts to get creative with signing releases and other face-to-face tasks. This is where the importance of building relationships with stakeholders across mental health and criminal justice fields really shines. What we're seeing is folks are really coming together and going that extra mile to make things possible, even in this unique environment. So in terms of prioritization, like where do you start? This is a big process. Identifying a leader or champion is important. Bringing together those stakeholders from criminal justice, behavioral health, and substance misuse recovery communities. Building that model, it doesn't have to be perfect. If you have a criminal justice advisory board, use it. If not, just start getting some folks together and building a model. Next is really about ingraining it into practice. Talk about it with programs. Collaboration across intercepts should be incorporating the model when engaging with identified stakeholders within your own intercept, as well as those key transition points between intercepts. And then leveraging opportunities is really important. There are sometimes political moments that provide an opportunity to really bring the sequential intercept model champion to the fore and talk about how the model works as a system, not an isolated series of events. Again, the sequential intercept model really should be grounded in the community whenever possible. As many people who can be served at earlier intercepts should really be served at those entry levels rather than relying on criminalizing symptoms of people's challenges and then serving their needs at later intercepts. Finally, keep building. This is a marathon, it's not a sprint, so start small. Celebrate your early successes, and then keep building through the intercepts as time, energy, and resources allow.
Okay, so I really want to thank Stephanie and I want to thank Jesse for their wonderful presentations today. And I want to remind individuals, we've been receiving questions in the Q&A pod on the right-hand side over the course of both presentations. But I want to give you an opportunity, if you have some additional questions, and it looks like we have about 8 minutes or so, no, maybe not, maybe about 4 minutes, we can answer a few questions. But in the meantime, you'll see that a file transfer box has just appeared on your screen, and there are 2 documents that are available for you to download at this point. You have the webinar supporting document, which you can download now, and you have a certificate of completion, which you can download from the file transfer box as well, just by clicking on the file name. And the certificate of completion, let me just move this box over here. You can see the certificate of webinar attendance. It says it is for your personal portfolio use. This is not a certificate that would earn CEUs. It's not certified by any accredited organization, but we know from experience that persons who have attended, participated in our webinars have been able to use those for other internal purposes. So please do download that certificate of webinar attendance if that's something that you think you would find useful. Here is another place where you can download the webinar supporting document by clicking on the link, or either in the file transfer box or here on the screen. And during the discussion group, we're going to leave the file transfer box open so that you can continue to download if you're not able to download right now. If you would like to receive additional information about subsequent webinars in this series or really in any of the offerings by the Gaines Center, we would strongly encourage you to subscribe to the Gaines Center listserv to receive notifications not just of upcoming webinars, but also any type of grant opportunities. So the Gaines web listserv would be something that would be very helpful for individuals. So we really want to thank you. We know that this was this first hour of your time that could have been spent doing some other things, but we recognize the importance of working with colleagues and learning from colleagues and sharing information with each other as we all move forward in our efforts to try to better serve our clients who are justice involved and have mental illness and or substance use disorders. So thank you again for participating. And now we want to invite you to please stay for the next hour and to become part of the discussion group. During the discussion group, all persons will be, you'll have an opportunity to either type a question into the Q&A pod or to raise your hand. We'll unmute you. You could ask a question. We already have maybe 9 or 10 questions that have been presented to us which we weren't able to get to during this regular session, which we will address during the discussion group. On the slide that is in front of you that is entitled Join the Discussion, you'll see at the bottom it says if you've registered for the discussion group, you can join by dialing into, and you see the Adobe Connect link there, and there's a conference number and a conference code. So if you, and we hope that you are staying for the discussion group, if you want to enter the Adobe Connect room now, and we'll be starting the discussion group in roughly, soon, okay, very soon.